I'm not getting there now.
Okay. Diane, do you wanna start?
Sure,
And
sure.
I'll
Well, thank you all for joining tonight. It's 8 o'clock. It's for me, it's late. I'm usually getting ready for bed at this point. So I hope I can be as lively and keep you awake as possible. And Terry and I had decided that we should do this before before the end of Medicare's open enrollment period, December 7th, to help you understand sort of the issues that Medicare Advantage presents. And I wanted to start, though, by just saying that, as I'm sure you know, there are many people who say they're very happy with their Medicare Advantage plans. And, millions of people probably are happy. And there is one reason for them to be happy, and sometimes more than one. And that is that when you sign up for Medicare Advantage, you have an out-of-pocket maximum, and therefore you don't have to invest in supplemental coverage to protect yourself from financial risk. And obviously saving that cost, which can be easily $2,500, $3,000 a year, is huge for a lot of people. And then there are sometimes valuable additional benefits in Medicare Advantage that people can't get in traditional Medicare. So there is that, and I don't want to deny that at all. And I also want to say that there are very likely a few really good Medicare Advantage plans, ones that would actually provide you with first-class cancer care and heart care and stroke care and care for your costly conditions. But the problem is we don't know which ones those are. And so when we talk about Medicare Advantage, we talk about it as if every Medicare Advantage plan is the same, even though we're told, well, choose the one that's right for you. But I'm here to tell you that you can't, because the information isn't available. And you can't assume that the one that you're choosing is going to meet your needs. So Terry, let's start with the first slide that sort of gives the overview of what's wrong with Medicare Advantage. Can you get that up?
Oh, yes, I can.
And I will
Hold on,
keep
can you?
talking while you get it up.
Good.
There are sort of four big buckets of issues. There's the quality issue, there's the cost issue, there's the reliability issue, and the accountability issue. And what I would say is that now Medicare Advantage, or private Medicare, has been around for 35 years. And to date, the government agency charged with assessing quality says every single year that it doesn't have the data. It doesn't have the data to assess quality in individual Medicare Advantage plans. And so we don't know what's going on in those plans and whether people are getting the care they need. What we do know from MedPAC, the Medicare Payment Advisory Commission, is that Medicare Advantage has cost more than traditional Medicare every year since its inception. And we also know that it brings a ton of administrative waste to Medicare. By some estimates, $800 billion a year in administrative waste because of all the negotiations, proprietary negotiations they have with doctors, because of their administrative fees, because of their profits. So there's just it drives up costs in big ways. And then it presents many administrative and financial barriers to care. And things are always changing. So the network that you see today may not really be the network. There are always problems with their provider directories, and their rules for coverage can change at any time. Their doctors come and go. So if you're signing up because you're counting on seeing particular doctors or not having to worry about coverage for a particular service, that may not be the case when you end up needing that service. And then finally, accountability is a huge issue for this very reason, that everything's always changing, and then their data is proprietary. So it's very difficult for the Office of the Inspector General to oversee and monitor them. And for whatever crazy reason that I cannot explain, when the Office of the Inspector General does monitor them, they won't name names. So they'll come out with reports saying, widespread inappropriate delays and denials of care in Medicare Advantage, but it won't say, these are the plans that you need to worry about. And so that to me is cause for major concern. Okay, Terry, next slide. So here's what's wrong with Medicare Advantage in pictures. And since a picture is worth 1,000 words, I guess you're looking at 4,000 words, and I'm going to try to bring it down to 400 words of explanation here. First picture, the first picture is to suggest that you're playing a game of Russian roulette when you choose a Medicare Advantage plan. So long as you're healthy, you're set. And if you get sick, that's the issue. It might be great. You might get everything you need, but you can't be guaranteed you're going to get to see the doctors you want to see or use the hospitals you want to use. You can't know whether you're going to have to go through prior authorization requirements and whether you're going to get denied and whether you're going to have to appeal and what your out-of-pocket costs are going to be. So problem number one. Problem number two, and this just defies reason and logic, but a lot of what Congress and the government do defy reason and logic. The way that Medicare pays these Medicare Advantage plans makes no sense. It pays them upfront a fixed rate. And they get that rate if they deliver no services or they deliver a lot of services. And they make more money, obviously, the more money they can keep. So their financial incentive is to spend as little on care as possible. And that can be a problematic recipe for good healthcare coverage. Okay, next picture, here today, gone tomorrow. That gets back to the point I was making about reliability in Medicare Advantage. You can't count on almost anything. Even the plans themselves can come and go. They can change their policies and practices all the time. Your copays can change. You just really have no sense of what you're getting tomorrow, even if you have some limited sense of what you're getting today. And then what do they have up their sleeves? We know almost nothing about an individual Medicare Advantage plan's denial rates, mortality rates, and disenrollment rates. But some we do know have very high disenrollment rates, disproportionately high disenrollment rates from people who are sick, who probably aren't able to get the care they need and want to switch back to traditional Medicare. And sometimes that's an issue, and we can talk about that during the Q&A. But at the end of the day, because they are so unaccountable, we just don't know enough to be sure when we sign up for a plan that we're going to get what we need. At the same time, as you all know, enrollment in Medicare Advantage is growing fast and furiously, and that's largely because they're leading people to believe through their advertisements, through Joe Namath, that they offer something more for less. And I think, I was trying to think of a good image, and the only thing I could come up with is just imagine a house with beautiful curbside appeal that you can't go into. And then another house that is less beautiful on the outside, but that you can inspect thoroughly on the inside. Which one are you going to buy? Are you going to take the risk of the beautiful house with curbside appeal that you can't go into, that could have a leaking roof and, all kinds of other issues, termites? Or are you going to want the house that you can inspect, even if it maybe isn't as attractive for certain reasons? And that's, I think, what we're getting at with Medicare Advantage. The attractive house could be perfect on the inside. We just don't know because we can't inspect it. Next slide. Okay, so I want to take a deeper dive here and focus on each of these four areas individually. On the quality front, what I'd like to say is I would sign up for any Medicare Advantage plan that was out there saying, we want you if you have cancer. We have the best cancer program in America. We're going to provide you with first-class cancer care. We can show you our record for our cancer patients, and the out-of-pocket costs are limited. You want to join us. That's the Medicare Advantage plan I think we need, everybody needs. But instead, we're told about their gym memberships. And the one thing about healthcare that the Medicare Advantage plans would like you to forget is that you're buying health insurance not only for today, but for tomorrow. And I'm sure, like me, you guys all know people who were in incredible health one day, and then the next day, they got hit by a car, or they fell and broke a hip, or they got diagnosed with some serious condition. It just happens. It happens to all of us at some point, or it happens to almost all of us at some point. I mean, eventually we die, right? So there's a point at which we need good care, and we don't know if that's tomorrow or next year. And so again, it gets back to this gamble. And again, because of the way the government pays these plans, regardless of the services they deliver, they get paid up front. They have an incentive to avoid providing you with first-class care. So if you're in Texas, you'd probably want to know if your Medicare Advantage plan has MD Anderson in its network. Can you go visit, the best cancer center in Texas? If you can't, I would say stay away. That's really important to be able to get first-class cancer care if you happen to get diagnosed. And I want to say here one more thing. If you think about the government as a huge purchaser, it is just stunning that they pay up front, because there is no large employer that pays a capitated rate to an insurance company on behalf of its employees. They pay for the services the employees receive, plus an administrative fee. And that's what happens in Europe. When you hear about plans in Europe, private insurance plans that people like and that work well, they work well because of the way that they're structured. They're structured to have to follow certain protocols. Medicare Advantage plans have to provide Medicare benefits, but they don't have to provide the same services as traditional Medicare. They call the shots on the services you receive. So you can get cancer care, but you may not be able to get the technology that you could get in traditional Medicare, because they might have prior authorization requirements, and they might force a doctor to take a lot of time to explain and justify why an expensive procedure is necessary, and the doctor might not prevail. They come between doctors and their patients to lower the cost of care. And again, here I should say that, the best possible Medicare Advantage plan may be actually serving its enrollees really well. And so again, they could be out there, but we don't know which ones, again, those are. And what we do know is that we're talking about health plans that are offered by, corporations that have shareholders and whose first obligation is to return high profits to the shareholders. So given the fact that they have the freedom to decide the care that's medically necessary, to overrule doctors, that they get to do so in secret, so we can't even easily challenge their protocols for what is necessary. It becomes, questionable whether or not you're going to get the care you need. And then if you happen not to have an advocate by your side, the stress and time it can take to challenge the plan can be beyond overwhelming. Whereas again, in traditional Medicare, you go to the doctor decides the care you get, and there's no administrative barrier. Okay, so let's move on to the next slide. And look at cost. So there are two cost buckets. There's the cost to the government and cost to individuals. On the cost to the government side, the Medicare Advantage plans are making out like bandits. They are getting an average now of $140 a month more than traditional Medicare because of the way they're paid. I told you they got paid a fixed rate based on the cost per person of traditional Medicare in their area, but they get paid additional money if they can show additional diagnoses for each of their enrollees. So they spend, or many of them spend, a lot of time and money getting doctors to put in as many possible diagnoses for their patients as they can. I mean, this is legitimate. These diagnoses they should be legitimate, and that drives up the payments to the Medicare Advantage plans. But in the process, we're draining the Medicare trust fund of money because these additional payments are actually not related to the number of services people receive. And so it's not that they're getting more money to provide more services. They're getting more money because they found more diagnoses codes for their patients. And then from the individual's perspective, the Part B premiums are going up because when the plans, Medicare Advantage plans, are paid more money, that affects Part B premiums because individuals pay 25% of the cost of Part B in premiums. Finally, there is one huge question mark with Medicare Advantage that is worth spending a little time talking about, thinking about, which is, well, what does a typical person in Medicare Advantage spend on their care? And that is one big question mark. They have not had to release that information. And so you do begin to wonder whether the average payment for people in Medicare Advantage isn't close to what people would have to spend for a Medicare supplemental policy in traditional Medicare. And this is an important point, which I actually have not spent enough time writing about or thinking about. But with traditional Medicare, when you have supplemental coverage, which, as I mentioned, costs about $2,500 or $3,000 a year, that's it. You're pretty much done. Your costs are almost entirely paid for. So you and your family can go to sleep at night knowing that if, God forbid, you need medical care, you can go to the doctor, you can go to the hospital, you can get a second opinion, whatever it is you need. And basically, all your costs are going to be covered. All your medical and hospital costs are going to be covered. But with Medicare Advantage, you are forced to make a choice that nobody should have to make. Basically, you have burning in your heart, and you're wondering if you're having a heart attack, but it could be heartburn. And you're saying to yourself, oh my God, if I go to the emergency room, I know it's going to cost at least $100 for, my deductible and another $100 for my copay, and I could be paying more money for an ambulance, and I think I'm just going to stay home because I'd rather not spend that money. Well, that to me is not a choice anybody should have to make to save $300. And it's not a choice anybody should make. It's just it's immoral to force anybody to make that choice. So yes, in Medicare Advantage, you don't have to pay for supplemental and insurance coverage. But what you do have to do is think about the cost of care every time you are going to the doctor or the hospital, and worry about the cost of care every time you're going to the doctor or the hospital. And that puts people in a position that is really untenable. And it penalizes people, obviously, based on their ability to pay. It discriminates against sick people, and it discriminates against people with low incomes. Okay, next slide, please. Okay, so just to hammer home the unreliability point, if somebody says to you, pick a plan that's right for you, a Medicare Advantage plan, it's just a meaningless statement. I can tell you I've been doing this for way too long. I think I'm going on into my fourth decade. It's been 30 years I've been working on this. And I could not tell you what the best plan is. The best I could do is say to you, look at your out-of-pocket cap. Some of them have out-of-pocket caps of as high as $7,550 a year. And then others have, $5,000 or $3,000 out-of-pocket caps. So if money is really your primary concern, saving money, then the out-of-pocket cap is going to play a major role if you get sick in keeping your costs down. And then talk to your doctors about which plans they're in and which plans they think give them the freedom to provide their patients with the care that they need. As I mentioned, the costs can change all the time. So if you're in a Medicare Advantage plan now and you're happy with it, you better still check to see what those costs are going to be next year and what the changes are next year. Don't assume that anything is going to stay the same. Nothing. The plans sort of rely on the fact that almost nobody bothers to check, and then they change things up, and you're stuck with much higher costs and potentially, a need to change providers. That's true too, I should just add, on the Part D prescription drug coverage side. That is, a choice that people in traditional Medicare make independently. And that's one that you should be looking at very carefully again this year. In Medicare Advantage, you should be picking your Medicare Advantage plan if you're going that route, in part based on what the Part D coverage is. If you're on a lot of drugs, that's a separate cost, and it could be very, very high in some Medicare Advantage plans and much lower in others. So again, I think the problem with these plans is you can have one really good leadership team focused on giving people high value care today, and then that team can be completely switched out, and there could be new owners. The plan can leave the market. Everything can change, and so here today, gone tomorrow is not out of the ordinary. And I probably should just, again, compare to traditional Medicare. It's just a constant. I mean, your job in traditional Medicare is to find good doctors and find good hospitals, and that takes some work. But you can go to almost any doctor or hospital and then not worry about the cost of care if you have supplemental coverage. Okay. And I should finally say on this point that, as I mentioned before, there have been several studies of Medicare Advantage and how what happens to people with costly and complex conditions. Most recently, the Office of the Inspector General released a report on end of life care in Medicare Advantage. And once again, what they found was that people at the end of life who needed a lot of care wanted to switch out and go back to traditional Medicare. to get the care they need. And that's not always easy, and nobody should take for granted that they can. And that's another big problem that we're working to address. But once you're in Medicare Advantage, most people are locked in. And I'll explain why during the Q&A. Okay, next slide, please. On the accountability front, we have this huge problem because the government really can't protect you. It can't oversee these thousands of Medicare Advantage plans to the extent oversight is warranted. And moreover, even when they find problems with Medicare Advantage, the punishments, they are minimal. And so there is, for the bad guys, and again, I can't tell you which ones those are, but for the bad guys, I mean, the punishment is a slap on the wrist often, as compared to the money they can rake in, doing whatever they're doing that could be jeopardizing their enrollees' care. But we don't know in many instances whether the provider networks are going to meet people's needs. We don't know whether their medical necessity protocols, which are the rules that they follow to decide whether a particular service is warranted, are in compliance with standard medical practice. Yes, they're supposed to be. Legally, they have to be, but they're not following the traditional Medicare protocols, which are public and online. They have proprietary ones. And so, again, we don't know how they're making their decisions and whether the way they're making their decisions about what care should be paid for and what care should not is appropriate. Prior authorization, I just read a piece yesterday, I think it was in Medscape, where there was an oncologist talking about how a Medicare Advantage plan's prior authorization requirements, he believed, killed his patient because he wanted to provide a particular service to the patient, and the plan denied that service at first, and took several weeks before it approved that service because the doctor was persistent. And by the time it approved the service, the cancer had spread and the patient died. So those kinds of delays don't happen in traditional Medicare. And to the extent that there are rules about how long Medicare Advantage plans can take to make a decision, they're hard to enforce. So, things happen, paperwork gets lost, phone lines get tied up, information, it goes missing. So you just don't know what's going on or why the delays are happening. But what we do know, again, as I had said, is that the Office of the Inspector General has found high levels of inappropriate delays and denials of care and coverage. So again, if there were true competition in this market, as there is in the television market or the housing market or the restaurant market, we'd know who the good guys were. We'd know, okay, we want to avoid these bad guys and we want to focus on the good ones, but we don't have that data. There's nobody out there who has that data. And so we're really going in blindfolded. Next slide, please. So, how troubling is this problem? Again, I mean, from my perspective, the key measure of good health insurance is whether it meets the needs of people with costly and complex conditions. And we don't have an answer to that question. It's a small percentage of the Medicare population any given year, maybe 20%, maybe fewer, maybe 10% of the Medicare population really has high costs. And so what's happening to them? I mean, the surveys don't capture what's happening to them because most of them can't complete those surveys because they're suffering from serious conditions. But what we do know is that there was a recent study that found high mortality rates in some Medicare Advantage plans. And that study said that if CMS, the Centers for Medicare and Medicaid Services, were to terminate terminate its contracts with the sort of the worst, or the 5% of Medicare Advantage plans with the highest mortality rates, we would save thousands of lives. But again, no names named. CMS hasn't done anything about that. I can't tell you that the study authors are got it right, but I can tell you that NBER, which is the National Bureau of Economic Review, is one of the most esteemed publications, and that the authors of the study were from Yale and Chicago and the top universities. So it could be legitimate, and it's certainly cause for concern. Okay, let's move on to the next slide, Terry. So where are we now? I didn't update the slide, so let me just let you know that, if you don't already know, that the House has passed the Build Back Better bill, Build Back Better Act, which does begin to allow Medicare to negotiate drug prices for 60 drugs and caps people's out-of-pocket costs for insulin at $35 and provides a hearing benefit in Medicare. Yes, it is true that many Medicare Advantage plans now cover or say they provide hearing, dental, and vision benefits. But in almost all of those plans, if you look carefully, you'll find that the copays are astronomical. And if you look at the data, what you'll see is that people access those benefits as much in traditional Medicare without insurance coverage as they do in Medicare Advantage, because the coverage is so limited in Medicare Advantage that it's tantamount to not giving people a benefit that they can use unless they have very deep pockets. So we're going to have maybe a hearing benefit, maybe 60 drugs, the highest Medicare spending drugs regulated. But what we're not going to have, and that I've been focused on, is an out-of-pocket cap in traditional Medicare, which would put it on a more level playing field with Medicare Advantage. That seems, it's not a high cost benefit, and it would not, if people would still then have to make the same decisions that they make in Medicare Advantage today between getting care or not, if there were just an out-of-pocket cap. But at least it would allow people to move freely between Medicare Advantage and traditional Medicare without having to buy Medicare supplemental coverage. Next slide, please. So final slide, actually. What's going to happen on the road to Medicare for All, which I know Terry supports, I support. I think that our best bet is to focus on making traditional Medicare a meaningful choice for people, and then focusing Congress on taking back the overpayments from the Medicare Advantage plans and not giving them the discretion that they currently have to deny care sort of without accountability, and to hide their treatment protocols and prior authorization rules from public view and scrutiny. So with that, I spoke too long, but let's take some questions.
First question that was in the Q&A or in the chat was about the star rating system. Can you expand on that?
Yes, it's a farce. Do not trust that rating system to save your life. The way they rate plans is based on factors that I won't go deeply into, but do not begin to capture what you need to know that you were in a plan that was first class. I think it's fair to say that you want to avoid the plans. If you're going to go that route, you want to avoid the plans that aren't 5-star, but don't assume that a 5-star plan is any good. just assume that the 1-star and 2-star and 3-star plans, which are few and far between, because again, there's star inflation as well, that the 5 stars mean anything. And that's true for nursing homes and hospitals as well.
Okay, Jay has raised his hand. I guess you have to unmute Jay.
Yes, now I'm unmuted. Thank you. Well, I have a couple of questions. One, you've talked. I'm a little confused about whether Medicare Advantage is supplemental to traditional Medicare, but at times you seem to be speaking of it as if it were an alternative to traditional Medicare, and so I'm a little confused about
I'm so
what the
sorry.
relationship is.
Okay, that's an excellent question. I should have been very clear. You have the choice as someone with Medicare between traditional Medicare and Medicare Advantage. You can only take one of those. Medicare Advantage is an alternative to traditional Medicare. If you choose Medicare Advantage, you are out of traditional Medicare.
And so, well, just to be specific about my own situation, I have Kaiser insurance, and their Medicare Advantage, or what's equivalent to that, I believe is called Senior Advantage. In addition to having about $150 a month deducted from my Social Security payments, I pay an additional $100 a month for what they call the Senior Advantage program. And of course, that being in Kaiser system, that limits me to Kaiser physicians. So I'm aware of that, but I'm unclear, and I have not done the careful analysis to know which parts of my coverage are coming from the basic Medicare that I pay to the government and from the Senior Advantage that I pay, as far as I know, directly to Kaiser.
Okay, excellent question. And I shouldn't have assumed that was clear to everybody. So everybody with Medicare, all 63 million people with Medicare, have Part A, which is the hospital insurance that almost everybody gets for free because we've paid into Social Security during our working lives.
Right.
And then everybody, all 63 million people with Medicare, or almost all, have Part B, which is the medical insurance side. And that's about $150 a month for most people. It's going up to $170.10 a month starting in January, but your Social Security check is going up almost 6% as well. So that should more than cover the $20.
Yes, it will.
So that's, everybody's paying that. So everybody pays that to the government. Medicare is a government program. But then, because you're in Kaiser Senior Care, you're actually in a Medicare Advantage plan.
Right.
So the government is taking the money it would have spent for you in traditional Medicare and giving it to Kaiser to provide you with managed care. And then you're paying Kaiser an extra $100 a month. I'm not sure for what, but what I will say is, just anecdotally, Kaiser is a nonprofit plan, and of all the plans out there, people seem to think that it does a very good job of managing people's care and providing people with the care they need. It's not accountable to a bunch of shareholders. It's not a Wall Street managed care company. So it is different in that regard.
And do you agree with that general assessment that?
I have no idea.
You have no idea. Okay.
I have no idea, because they don't share their data either.
Got
But
it.
what I would say is that, it's conceivable that they are, doing better because they're not profit driven in the same way that a for-profit plan is. But
Thank you.
That's all I can say.
Okay, we have Walter with his hand up. Can you want to make a comment, Walter?
Yes, hi. So I'm Walter Weiss. I'm a Unitarian. I'm in Bethesda, Maryland at River Road Unitarian Church. I'm also a doctor and an MPH, Master of Public Health, and I do a little teaching at Georgetown Medical School with the medical students, giving them an introduction to policy and health insurance. So I'm far from being as expert on this as Diane is, but I just want to sort of put this into a context. Like, so I think we all agree as Unitarians that we should have national health, single national health insurance, which covers everybody. We're really so far out of sync with what all the other wealthy countries in the world are doing. And I think, really we need to be working for that through our Unitarian legislative ministry in our various states and nationally. The US, though, has specific problems. Medical care in the United States is so expensive compared with other countries. And there are a variety of different reasons for that. It's not that we are healthier. We don't get more, more health for those extra dollars we spend. It's just that our system is set up in a very perverse way. This whole business of, well, Medicare is great, you only pay for the services that your doctor provides. That is a financial incentive for them to do more services than you need. An example is, if you go into a hospital and get your appendix out and you go home, well, the doctor gets, one payment for one operation, the hospital gets a day or two of, inpatient care. But then if you get a complication, if you develop, peritonitis from that and have to go back in the hospital, well, the doctor gets more money because he did a bad job. He now has to give you more treatment and he gets paid twice. And the doctor in the hospital similarly goes, you have to go back in for a week of antibiotics and the hospital gets to bill you again. So there's this perverse, that's sort of the worst example, but it's not too dissimilar to many other things where the design of our medical system, where we're paying for services, is an incentive to do more.
So can I interrupt for a second?
Doing more is not necessarily better.
Well,
So I'm just, okay, so please let me finish, Diane. Okay. I don't want to debate this. I just want to make a statement and then I'll be quiet. So I really am not a fan of the traditional medical care in the United States, which is supported by Medicare right now, standard Medicare. I think it has financial incentives to do too much and to pay doctors and hospitals too much. So basically the whole system of HMOs, which is really what Medicare Advantage was set up as to try to keep a handle on the cost. Costs right now are 20% of the whole US economy going to healthcare, which is an incredible drain. That means all that money cannot be used for education. It cannot be used for any of the other things we want to be done. It's all going to healthcare. And that's growing. So how are we getting, so HMOs were an attempt to limit the cost. And they do this, as Diane says, they give a single payment, flat payment to the health plan, the capitation. And the goal here is that they want the health plan to keep you healthier. If they can keep you from needing that operation, they save money. So it's all economically driven. They want, the idea was if they can make the company, make the HMO do less care, that will save money. Now, of course, the flip side, as Diana was saying, is they need to do enough care. So how do you balance that? Very difficult. So how does this leave us as consumers? Because really what Diane has been talking about here is from the consumer level. What do you sign up for? What do I sign up for? How much do I pay for this? How much do I pay for that? Well, you know, it's incredibly complex. And I don't think anybody would deny that it's really unbelievably complex. I mean, doctors at Georgetown who teach public policy with me are free to admit that they signed up for the wrong plan. You know, they looked into it and they made completely the wrong decision. It's so complicated. So it's not great. But as Diane was saying, there are millions of people who are happy with their Medicare, and there are millions of people who are happy with their Medicare Advantage plans. So, you know, and so I don't really, you know, have an answer to this. I think that as UUs, we should be thinking of the greater good when we make our decisions about our own expenses and whatever we think is going to help keep US healthcare costs down, whatever is going to allow you know, a movement toward Medicare, toward universal health care, whether it's Medicare for all or some new system. I think that's where we should be.
Hey, can you share the floor with some other people, please?
Yeah, I'm going to shut up now, but thank you very much.
Thank you, Walter. Yeah,
Let me
Mary,
just,
you've
can I
been
respond?
waiting.
Can I just respond for 1 second? There is no perfect payment system. We can pay fee for service, we can pay capitated, which is the fixed rate that Medicare Advantage is paid, or we could pay salaried, or we could pay some hybrid. And each of them has strengths and weaknesses, as was just explained. But if you believe that most individuals are motivated to do good, then you can assume that most doctors are not inclined to overtreat, although maybe you don't want to assume that. In Medicare Advantage, you have the worst of both, because you have a capitated payment to the Medicare Advantage plan. And then you have the Medicare Advantage plans, the publicly traded ones, not the Kaiser, paying their doctors on a fee-for-service basis. And so you have exactly that incentive in Medicare Advantage that was just described to overtreat to the same degree as you do in traditional Medicare. But I will also say that every other country, developed country, provides better care based on, you know, analyses in terms of quality than we do, and they all pay on a fee-for-service basis with a global cap.
Well, Mary, you've been very patient.
Oh, no, that's quite all right. I am just going to say that I wear two hats in my question. One is as a family practice PA working at a underserved community clinic where we have a fair amount of Medicare and Medicaid patients, and also a lot of uninsured. And then I just turned 65 myself. And so I've started entering into my individual decision, and I find it actually quite daunting to sort through this, as has already been stated. And so a couple of things that I did want to say about just healthcare in general. As a primary care provider, there's an incredible fragmentation of care, and that's what's driving up a lot of costs. And primary care providers who know how to do preventative care are underutilized, and instead the money goes to specialists and hospitals and procedures and all of that. I mean, if I can save you from a heart attack by helping you to lose weight, control your blood pressure and your diabetes, then isn't that more cost effective? So this is a push for primary preventative services, which would really save us money. But my question is, and this is because I have faith in what government does, and I know that's a lot of question right now, but I do believe that when this was first set up, the Medicare Advantage plans, I'm assuming Medicare did this with some intent to offer something beneficial. And it seems like, yes, the marketplace got a hold of it and some of it works and some of it doesn't. But going back to the history of what was the original strategy for setting this up, Diane, if you could please tell us, what was the thinking back then that Medicare said, yes, we want to do this, even though it's in competition to what we offer? Thank you.
That's an excellent question. So I think what happened actually is it started out in California where there were these nonprofit managed care plans that were doing a good job of coordinating care for their members and focusing on preventive care, as you say, primary care. And then I think what happened is that the for-profit corporations sort of saw their opportunity to get in and get in on the gravy train, and it expanded to include them. And I think what the Congress's thought was, well, if they can improve quality through care coordination, or they can save money through greater efficiencies, preventing overtreatment or whatever it is, that would be a value added. And yet, I think for whatever reason, the thinking stopped there and didn't continue on to, well, how are we going to know if they are delivering high quality care? And are we going to be able to get data from them? Are we going to be able to drive system improvements? I mean, one of my favorite stories is that in Germany, where they have private insurance, and it works apparently quite well, during the opioid crisis at the beginning, the German federal government said to the insurers, you are only going to pay for opioids in these restricted circumstances. And guess what? They didn't have an opioid crisis. But in this country, when we turn things over to industry, we don't have the ability to influence what they do. Even in the beginning of the pandemic, I was watching what the Medicare Advantage plans were doing in terms of helping their patients. Their websites were like at least 2 months behind the evidence. You couldn't get legitimate, they don't have that same obligation as the private plans do in other countries to deliver the information that the federal government wants delivered. And so you don't have the transparency, so you can't oversee them appropriately, and you can't learn from them. Like, we should be learning from our healthcare system, right? We should learn what's working and not working. And back to Jay and Kaiser, I did speak at one point to the former CEO of Kaiser, because what I had heard was that Kaiser does a very good job of learning from its patients about what's working and not working, but doesn't share that information. And I said, what value is there if you're not sharing that information? You're learning about medical devices that don't function, but we don't know. And there's a fear of lawsuits. And then he said to me, he went on to say, it's way more than that. We're learning about surgical procedures that work and those that don't work. He said, someday we'll be able to share it. But again, that's just kind of it just seems like such a waste. I mean, and this is obviously bigger than Medicare Advantage, and this goes back to government, but that's the way other countries do it, right? They're constantly learning and changing and evolving based on what they're learning. And once you rely on the private marketplace, you can't learn in the same way or drive the system improvements that you need.
Okay, Rebecca has a question. And then Lucy will ask after that, I guess.
So I know there are specialized Advantage plans for people with certain conditions like heart conditions or diabetes, and there's others. I don't know that these are available just anywhere in the country. You have to have one of these conditions to get these plans, and they'll kick you out if you try to enroll in one and you don't have these conditions. So they advertise that they have targeted care and they're going to provide better care for these conditions. Does this approach work? Do you know how these plans compare to just your run-of-the-mill Advantage plan?
Yeah, I think everything I said about the run-of-the-mill plans applies to these plans. We have no clue. And just to say it, if you have a heart condition and you join this plan because it's for people with heart conditions, what happens when you get diabetes and cancer? I mean, health, we don't know what's going to happen to us, right? So a specialized plan may meet people's needs. We don't have the data. We don't have the data. It's that simple. And if you're in traditional Medicare and you have to, it's not that easy. This gets back to Walter's point, to know which doctors and which hospitals are going to deliver the best care to you. But you have the ability to do your homework and go to the ones that can. And also, most Americans do some traveling. And, if you're traveling, again, your care is covered anywhere in the country with traditional Medicare. With Medicare Advantage, if you move around, just even if you have to move in with a family member out of state because you get sick, you got to start all over again. You're not going to get your care covered with your Medicare Advantage plan.
Okay, Lucy has a question. Need to unmute. Well, I'll read it. I have heard that there are problems, including financial, switching from Medicare Advantage to basic Medicare. Can you share what you know of that?
Yes, I can. I think it's an important issue. So basically, the government not only doesn't have an out-of-pocket cap in traditional Medicare, so people need to buy supplemental insurance to fill gaps, but it doesn't give people the right to buy supplemental insurance, except in very limited instances. So, when you first enroll in Medicare, you do have the right to buy supplemental insurance, and the insurer can't discriminate against you and charge you more because of your health conditions. Everybody gets charged the same amount. But if you go into Medicare Advantage and then want to switch to traditional Medicare, you could find, depending upon the state you live in, that there's no Medicare supplemental insurer that will sell you coverage. And many people do find that. They are allowed to medically underwrite, meaning they are allowed to refuse you coverage or charge you an enormous amount for your coverage if you want to switch and buy a policy. So that's why people who sign up for Medicare Advantage end up often locked into their plans, their Medicare Advantage plan, and can't ever go back to traditional Medicare. Now, that is not the case in New York, Massachusetts, Connecticut, and
I think Washington State.
well, I think Washington State does not have guaranteed issue community rating. There's one other state in the Northeast, Maine, has guaranteed issue community rating, I believe. New York, Maine, Connecticut, and Massachusetts, I believe.
Supplemental program is not a government program. It's a private program.
That's exactly right. Although the federal government does sort of mandate that these private insurers offer only standardized plans, which is good. So it's not so confusing. And that they sell insurance to people with Medicare in certain situations. So it's not only when you first enroll that you have a right. There's also a federal right when you move and lose your Medicare Advantage plan because you're moving. There's certain exceptions, but they're few and far between.
Thank you.
I have a question. I got the supplemental plan F, and I was advised that I should probably move because they're no longer enrolling anybody, which means, everyone's getting a year older every year in that pool, and so it could get much more expensive. But I'm not going to save any money if I qualify for the no underwriting plan, and if I don't qualify for that one, it's going to cost me about $70 more a month, plus I'll have deductibles and co-pays. Do you think that F plan's going to get really expensive in the next few years, or do you have any clue on that?
Well, no, I think that whoever advised you is correct that, once they close a plan, then the people who stay in the plan aren't getting fresh blood in the plan. And so that will drive prices up. If I were you, I should have said this earlier, every state has a state health insurance counseling and assistance program that provides free guidance. And Terry, if you contacted yours, they could help you understand what your options are and what the lowest cost plans are. Because it doesn't really make sense to me that you should be paying more if you switch to the plan G. But I don't know. It involves some homework for sure.
Yeah. Okay.
Plan F is a good plan. So if you if it's working for you now, you don't have to switch now. But
yeah, I have a friend who did the SHIP counseling. And, he was the one who said stay away from Medicare Advantage.
Yeah. Well, go.
Okay.
He could probably help you then with the Medicare options.
Sure.
Yeah.
Sally, you have a question?
Yeah, I was just on the Physicians for a National Health Program. So I got an email from them today about a rally they did in Washington about direct contracting for traditional Medicare, which sounds scary. Get your hands off.
Yeah.
Can you talk a little about that?
Yeah, I spent a lot of time with them on that. Okay, so the Trump administration, remember them? Not that long ago, in just as one of its final acts on the healthcare side was to launch a quote unquote experiment, and CMS, Centers for Medicare and Medicaid Services, are allowed to launch experiments that could possibly improve quality or lower costs than traditional Medicare. And so what the Trump folks did was really nefarious. What they did was they said, we're going to launch an experiment that allows insurers and investors into traditional Medicare and see if maybe they can save us some money. So I've spent the better part of a year fighting this. And a lot of it has been stopped, but some of it is still in play. And let's just hope it gets stopped soon. But insurers or investors in some parts of the country, for some people at this point, are allowed to, quote unquote, manage care for people in traditional Medicare. And we don't know what they're doing. We don't know how many people. There's just no information that's been disclosed yet about what's happening. And there are there's a lot of cause for concern. The one protection that people in traditional Medicare have that people in Medicare Advantage don't have is their ability to go to any doctor anywhere in the country. At the same time, the bigger risk is that there's less regulation of these insurers and investors. So God knows what they're up to. But thankfully, PNHP was out today knocking on members of Congress's doors. And I believe they also, I know they were trying to go to see Secretary Becerra on this topic. And I don't know if they were able to go to the White House, but that was also a potential visit for them.
We've also been working with Nurses United, which is targeting 4 particular representatives, 1 in each region of the country, on Medicare for All. So
that's great.
Yeah.
Our ship counselor said that we could conceivably just skip the Medicare Advantage and just work with just Medicare and then pay the deductibles and co-pays or whatever directly.
Oh yes, you can, if you end up in a direct contracting situation, you can opt out.
Mm-hmm. Good.
Yeah, but the problem is that
nobody will.
Well, that people won't even know that they're in. Exactly. But once they know they're in, they can opt out. Yes. Good point.
Yeah. Well, I mean, the insurance costs us on my policy about $2,700 a year or so, and considering you really only have to pay for what 20%, 25%? You said of doctors. I thought it was 20% of the doctor bills.
Yeah, 20% of the doctor bills. Mm-hmm.
Right.
Part B, Part B, I was talking more generally about Part B of Medicare. You pay 25% of the costs.
Okay, what else would that include? Besides
it includes therapy. It includes, I think home care is under Part B, medical devices and medical equipment under Part B.
Okay. Okay. Well, it seemed as though as often as we go in, even though I've had a few things happen, it's not been outrageously expensive.
Yeah. No, I mean, compared to commercial insurance, it's phenomenally fair, but it's still, it obviously takes a toll. I mean, 50% of people with Medicare have incomes under $30,000 a year. So $2,700 is big. Yeah.
Yeah. Okay, Mary?
Yeah, Diane, with all the flaws that we've discussed about Medicare in general and how convoluted it is CMS taking a look at all of this and saying, really, we've been pulling together a little of this, a little of that. We really have a big mess. Maybe we should find a way to streamline this. Is anyone recognizing that?
No.
Within the leadership of CMS?
Well, not to my knowledge, but again, just to say it, CMS has limited authority. It has a lot of responsibility and not a lot of power because it's checked by Congress and by the White House. And so sometimes their hands are tied. And Congress is certainly not saying, let's streamline this. They're not even saying, let's get back the overpayments, the hundreds of billions of dollars of overpayments. Let's forget about get back. They're not even saying, let's stop the overpayments to Medicare Advantage. So we're not in a good place.
I don't know if anybody is interested in hearing what happened to me this year, but I can tell it quickly. I retired last year and got on Medicare Advantage because it looked less expensive to me. But as I learned about the pros and cons of it from actual people talking about it, as opposed to the salespeople talking about it, I found that it really didn't have an advantage per se. and that I was actually getting locked out of the Medicare supplemental program. And unfortunately, I didn't act within, I believe it was 9 months.
No, you
You
have 12
have
months. You have
to
12 months.
12 months. Well, 12 months came and went, but I was able to switch into the supplemental program after being rated and underwritten and approved and everything. Finally got out of Medicare Advantage and into the supplemental. And boy, that is a real hurdle. So if people are thinking of doing this, get on it, because it takes time, it takes approvals, it takes answering all your medical information. So try and get ahead of it if you're thinking of making that change.
Good advice.
Sally, you have a question?
Yeah, just on that point, if one is on traditional Medicare and is considering changing supplemental providers, is that a free switch, or do they go through the medical rating issue with that? Do you know? Is that state by state?
That is an excellent question.
That's what I'm doing right now. Yeah.
I don't know the answer. I don't know the answer. It seems to me that if you already have a Medigap policy, they shouldn't be underwriting you if you're switching to another company, but it may be state law that applies. I don't know. I would call the state health insurance assistance program in your state.
I think I'm just going to fill out the application for the one I'm looking at and not drop the other one till I know whether it's yay or nay.
Exactly. Good idea.
Well, this has been interesting. I think.
Wait, I got one more quick question.
Oh, okay.
We've all seen Joe Namath and Jimmy J.J. Walker, and actually my mother keeps saying, is that government? Do you actually get more stuff? It's like, how can they run this? Isn't there a truth in advertising anymore? Can't we kill those ads somehow?
Yeah, it's interesting. There's going to be a story, I think, in the New Republic very soon on this exact topic. The company that runs those ads, I've been told, I haven't done my own investigating, but I've been told by a man who literally investigated it, that it's run by people who have been, criminally prosecuted in the past. I don't know if that's true, but I'm just sharing what he shared with me. And he's working to shut them down because they aren't the government, and people are misled into believing they are, and they're steering people into the plans that benefit them, not necessarily the plans that benefit the individuals who are calling. So it's an issue, but as far as I know, nothing's being done to stop it. And I don't understand why not, but let's see what happens when the story comes out in the New Republic.
What I started to say is this has been a really interesting evening, because almost everybody that has chimed in is a participant in this program, and we've all had differing experiences. So I appreciate your conversation. Do we have any more questions?
We're all exhausted.
Thanks for organizing this.
Well,
good information, Diane.
Yeah, no, thank you very much, Terry, for organizing. It was a pleasure.
Okay, well, good. You have a good evening, what's left of it, and
thank you. And come to justcareusa.org, my website, for lots of information about Medicare.
Okay.
It's a good reference. Thank you.
Okay, thank you. Bye.